This last of the stomach disorders, miscellaneous gastric, ties together some loose ends. We're going to talk about gastroparesis, cyclic vomiting syndrome, and then stomach cancer. Gastroparesis is going to take up the most. So let's start with that one. Gastroparesis. I want you to think of gastroparesis as gastric paralysis. And the stomach fails to empty. There's a lot of causes of gastroparesis, but the two you're going to see are going to be idiopathic, just happens, or diabetic. And diabetes carries something a little special. So most commonly it's idiopathic and you just have to deal with it. But it's also diabetes. And the reason why I say diabetes carries something special is that you're going to notice that diabetes is constantly listed in every step of the way, both patient presentation, diagnosis, and management. The patient with gastroparesis is going to present with delayed gastric emptying. So those symptoms are going to be chronic nausea and vomiting, often abdominal pain, especially with eating. And if they're a diabetic, they will have peripheral neuropathy. Here's why. Diabetic gastroparesis is a peripheral neuropathy of the vagus nerve. This is a brain. The vagus nerve comes out, esophagus, stomach, and it innervates the esophagus. In order for diabetes to cause a neuropathy of the vagus nerve, it will have impacted longer nerves. The nerves that go to the feet start in the brain as well, but are certainly longer than the vagus nerve. And so, because of the way diabetes works, causing damage to the nerves most distally, in order for a diabetic to have diabetic gastroparesis, there must be damage here at the feet in order for there to be damage at a shorter nerve like the vagus. And for whatever reason, even though the vagus nerve does a lot of things, the complication patients get from diabetic neuropathy of the vagus nerve is gastroparesis. Now, what you'll do in the management or workup of somebody with chronic nausea and vomiting is get them an endoscopy. What this does is it rules out other diseases, particularly gastric outlet obstructions, peptic ulcer diseases, and cancers. When the scope is negative, then you go on to the next step. And you'll hear people talk about, well, if someone has fasted overnight and there's still food in their stomach, they probably have gastroparesis. Not sensitive or specific, don't use it. The endoscopy is used to rule out other diseases because you don't know it's gastroparesis. They're just presenting with chronic nausea and vomiting, and you're doing the endoscopy for that. The way you diagnose gastroparesis is with an emptying study. What you do is you literally have them eat radiotracer and scrambled eggs, and you take a picture at 0, 2, and 4 hours. If there is more than 60% of the gastric contents at 2 hours, or greater than 10% at 4 hours, the test is considered positive. But to do this study, you must be off opiates, off anticholinergics, and have good blood glucose control, as all of these will delay gastric emptying. So you have to have the patients be off these things to do an emptying study, and it also becomes part of the treatment. So for all patients, you want to avoid opiates, which is troublesome because this often presents with abdominal pain. Avoid anticholinergics and maintain good blood glucose control. Now this is going to be tough because these are going to be the insulin-dependent diabetics who have really bad diabetes. And the way you normally do it is you give an injection of insulin 30 minutes before you eat. Because normally you eat 30 minutes later, and by the time the food gets in the duodenum and you start absorbing the glucose, the insulin kicks in at the right time. But if they've got delayed gastric emptying up to 2 to 4 hours later, they give themselves insulin, and then there's no sugar. So the very brittle diabetic, the diabetic that gets really high blood sugars preprandially and then really low blood sugars postprandially, is going to be someone who's got diabetic gastroparesis. So it becomes more challenging then to manage the blood glucose because it doesn't work the way it's supposed to. They don't get food into their duodenum because their blood glucose is high, but they can't get any insulin because they have to wait for the blood glucose to rise. But nonetheless, blood glucose control is paramount in maintaining gastroparesis. And then the best thing to do for these patients is prokinetic agents. There's 3 we're going to talk about. Metoclopramide, orally, erythromycin, intravenously, and domperidone. Domperidone is not allowed to be used in the United States. Compassionate use only, cardiac side effects. Metoclopramide and erythromycin both come in oral and IV forms. Oral metoclopramide is good chronically. You give it with meals 3 times a day. It maintains forward motility, and it kind of gets them into their normal regimen. If they present with a flare, erythromycin can be used. Erythromycin has tachyphylaxis, so it stops working after about a day or 2. But if someone comes in with an acute flare of gastroparesis and they're in the hospital, what you want to do is get them out of the hospital by getting things moving again so you can use IV erythromycin. So I want you to see oral metoclopramide as stable disease and IV erythromycin as a flare. Knowing that there are both oral and IV formulations and you can use them interchangeably, but this is how I want you to see it in general. And finally, something that might help, I'm not sure, but it's still recommended, is a low-fiber, small volume meal. So these patients are going to eat multiple times per day, but little bits at a time and low fiber. So gastroparesis is the big one of this lecture. Look for nausea, vomiting, abdominal pain, a negative endoscopy, emptying study, and then prokinetic agents. Also in this world of nausea and vomiting is going to be cyclic vomiting syndrome. Not well understood or characterized, but we know that it's linked to THC. So you're going to see an habitual marijuana smoker. This is someone who smokes multiple times per day, who then presents with intractable nausea and vomiting that occurs on a cycle. It's usually in the order of weeks. So they'll go weeks without any problem. And all of a sudden, terrible, debilitating nausea and vomiting. You get them through the flare, on the other side they're fine again, and then they come back with intractable nausea and vomiting. The thing is, if they just stop smoking altogether, it would go away. But when they get these symptoms, usually the marijuana makes them feel better. Unfortunately, it's also inducing the cyclic vomiting syndrome. So the diagnostic step is nothing, it's clinical. But chances are, when someone comes back over and over and over again, you're going to do an endoscopy to rule out other causes, and you might even get an emptying study. But the first time you see them, and after it's been diagnosed definitively by ruling out everything else, the treatment is to stop THC. In an acute flare, you can use metoclopramide, oral or IV, or erythromycin, oral or IV, to get the stuff out of their stomach. Any antiemetic will do in this case, including ondansetron, the goal being control their nausea and vomiting while they withdraw from the marijuana, and then they go on their way. Now, not everyone is going to experience this, and so it has to be something in marijuana with the right genetic haplotype that happens to make this happen. So this is not an intoxication or withdrawal syndrome that you should memorize for marijuana in general, but this disease is definitely associated with marijuana smoking. And the last disease we're going to talk about is gastric adenocarcinoma. We don't know that much about this disease either. Because it's so rare in the United States, we just don't have the incidence good enough to really figure it out. What we do know, though, is that it has an increased incidence in East Asia and has been linked to nitrites. That is to say, people who live in Japan and eat a Japanese diet filled with preservatives are going to end up with an increased risk of adenocarcinoma of the stomach. those same demographics that come from Japan and move to the United States and eat a Western diet don't have that risk anymore. So it is definitely environmental. We're just not sure what it is, but we think it's the preservatives, even though there has been an increased incidence in China. By the time a gastric adenocarcinoma presents, it's usually pretty advanced, and so what you're going to get is early satiety. And that is because there's literally a thing that's taking up the stomach, so they don't need to eat a lot to fill their stomach because it's full of cancer. They may have unintentional weight loss or gastric outlet obstruction. The preferred method to diagnose gastric adenocarcinoma is going to be an endoscopy, and you get a biopsy that shows you the signet ring cells, and then a PET scan or a pan-scan CT to stage. And the reason why you're doing that is because by the time you find it, 90% of the cancers are already outside of the local realm. It's going to be resection and chemo. And this has a very dim prognosis. All right, so we blew by cyclic vomiting syndrome. I want you to know about it. Marijuana, cyclic vomiting, treat them with antiemetics and send them on their way. Gastric adenocarcinoma, early satiety, weight loss, and gastric outlet obstruction. Get a biopsy, prognosis is poor, but spend most of the time on gastroparesis, where you're going to see the chronic nausea and vomiting abdominal pain, emptying study at greater than 60% at 2 hours, greater than 10% at 4 hours. Use prokinetic agents, oral metoclopramide for stable disease, IV erythromycin for flares, and stay away from domperidone except in compassionate use. And that is miscellaneous gastric.